when you review that to look at the one that asks, what changes will you be making in your practice based on what you learned this evening? That applies to everyone, not just the physicians on the call. And we're happy to have a list of basically what changes you make. This question, as well as the others, are important to our CME accreditation, both for nursing and for physicians. That email you will receive for the eval form will ask you to re-enter your name, email address. Please give us your full name, not a nickname or shortened name, and as much as your attendance certificate is generated based on what you put in this eval form email. If someone is watching, participating in the program with you this evening, and it's only one of you has logged on, please let myself or Mary know so we can be sure that the person with you gets appropriate credit for being on the activity. You will also see in the chat box at the end of the program a QR code through which you can access the eval form also. And if that's to your liking, click on it, and again, you'll see the same eval form that's emailed out. For our residents on the call this evening, please know that your coordinators, Darrell Johnson and Lori Galvez, they track your CME attendance. You do not have to keep up with CME certificates. Otherwise, your CME certificate will be sent to you when you send in your eval forms. Eval forms are not required of physicians attending or others except nurses and nurse practitioners for credit for the program. However, for nurses and nurse practitioners, it is required by the Virginia Nurse Association that you complete an eval form in order to receive credit for attending the program. Each time we do a program, I would like to take a moment to thank Mary Kent for her help in putting these programs together. She does a lot of work on the backside of these with the many documents required, and I'm very grateful for her help. Also, Jennifer Goodman, who now manages the nursing CE process, does similarly a lot of work to get nursing CE credit for the program, and I'm also very grateful for her help. Questions are encouraged. You can raise your hand through the chat. If you type in a question, Mary will be monitoring this, and these will be fed or made aware to Dr. El-Husseini, who will respond to those. If you have a verbal question to ask, which you're urged to do, or comments, please, once you've made your comment or ask your question, mute your phone so we don't get feedback. You're more than welcome to do multiple questions, multiple comments. Discussion is very much encouraged. Let me highlight a couple of programs, actually only one more for this first half of this year. June 5th, which is next Thursday night, we will be having the last in the 3 neurology topic programs. We're delighted to have Dr. Andrew Liu, a neurologist who was a dementia specialist at Duke University School of Medicine, talking about the diagnosis and management of dementia. Dr. Francis Walsh, a neurologist at Sovah Health on the Martinsville campus, will be moderating that program. Dr. Liu's presentation is extremely timely, in as much as the FDA just recently approved a blood test that can demonstrate risk for potential Alzheimer's disease. So I hope you'll be part of that program next week. This evening, we're delighted to have Dr. Neda El-Husseini speak to us. She began her educational journey for her undergraduate work at the American University of Beirut, where she graduated as a member of the Dean's Honor List and with distinction. She continued at the American University of Beirut for her MD degree, where she was selected for a membership in the Alpha Omega Alpha Society, which is the, if you will, Phi Beta Kappa version for medical schools. She completed an internship in internal medicine at the American University of Beirut, and then came to the Duke University School of Medicine Medical Center, where she did another internal medicine internship, followed by a residency in neurology. After that, she completed 3 sequential fellowship programs at Duke, including cerebrovascular research, vascular neurology, and clinical drug development. Finally, she completed a master's in health science at Duke before becoming a full faculty member and has now evolved into being the medical director for the telestroke program, of which Sovah Health participates on both campuses, as well as a number of other large academic and community medical centers. She has published numerous high-impact journal, peer-reviewed journal articles. She's authored 4 book chapters. She has numerous extensive research grant support, and she is just a delightful person with whom to work, and someone who's made a big difference in the life of so many patients presenting with acute stroke here at Sovah Health. So Dr. El-Husseini, if you'll bring your slides up, I think it will knock mine off, and we're delighted to have you. Thanks so much.
Thank you so much for this very kind introduction. Let's see, I'm trying to share.
I'm going to click on
Okay,
mine.
I think it's gonna work here.
Yes, just go to slideshow and you're good to go there.
Okay, are you seeing it in presentation mode?
We're seeing it where you have the the little thumb.
Yeah, you want to go to hide presenter mode.
No.
Or go down to where the full screen is and click on that.
This here.
Bottom right hand corner. See the full, like the projector screen at
Yeah.
the bottom ribbon. A little bit further.
Sorry, let me try.
It's all right.
Let's try again. Hold on, give me one moment.
Sometimes it just takes a second time and it works great.
We'll see. Yeah, I think it's doing the same thing with that.
Mhm.
You can also go up to slideshow in the top right, the top hit slideshow. You're almost there. You're close.
Is it here? Show us.
Slideshow right there on the red ribbon.
A little bit further over.
Here,
Next
you're
to
right.
animations.
you got it right. Is that okay?
No, you need to go to slideshow on the red ribbon with your mouse. That's my mouse. That's not your mouse.
Yeah, I'm not seeing any red ribbon, but I did
Okay.
swap the sharing. Are you able to see the full screen now or not yet?
Not yet.
Not yet.
At the bottom of your slide, do you have the option to hide presenter view? And you see things that look
Yeah.
like highlighters. So if you click on hide presenter view. Okay. Oh, that's weird. Usually when you hide presenter view, it goes to full screen. So
All right, I guess I'm not sharing anything now, am I?
Correct. You're not.
So
Okay.
the other option is that I can bring your slides up and then you can just say next or whatever. We can advance to the next slide for you. Which I know isn't optimal, but
That's bizarre. We tried it last time. It all worked okay. Let me try one last time.
okay.
So I have it.
Click on that.
And it looks like you're right on it. Yeah, it looks like you're right on it with your mouse.
Okay. So what are you seeing now?
We're seeing your slides and your upcoming slides to
When I
the
put
side.
here hide presenter view, is this any better?
Yeah, there's a little box, yeah, right below the mouse.
Yeah, nothing,
That
when
little
you click,
shaded one.
nothing happened when you clicked hide presenter view that time.
we can probably live with this if we have to. I mean, it's just.
All right. Mary, do you prefer that I send you the slides?
I have the slides. The only reason I say that is because of the denseness of your slides. It might be better as far as people being able to see them.
Okay.
So
Okay, let me, it's just, I'm not sure if I'm gonna be able to see them okay. I did update some slides. I'm gonna send you the most recent version while I try one more time.
okay.
While we're getting the slides up, I might just mention to everyone on the call that on July 17th, that's a Thursday evening, we will be having an update on measles diagnosis and, more importantly, how to overcome resistance to vaccination.
Is that working now?
Yes,
Okay.
perfect.
All right. I'm
Okay.
so sorry
Perfect.
about the trouble, but hopefully the rest of this will be, you know, better taken and more enjoyable for everyone. So today I'm gonna be, or this evening, first, thank you for joining on a Thursday evening to listen to updates about acute ischemic stroke. And as Dr. Moore mentioned, please feel free to interrupt at any time, to ask any questions or interact or share experiences or open any discussions. So there's quite a bit that I had put here. Again, for each one of those, this could be a talk on its own, but I really was hoping to give an overview of what are the main considerations that we have and all the major updates, especially the past 5 years, that have shaped how we think about taking care of acute ischemic stroke. So I'll start with a review of stroke definition and epidemiology, stroke symptoms, risk factors, some terminology and scales, so we're all on the same page when I go into the results of the major trials. And then we'll talk about updates in intravenous thrombolysis, including tenecteplase, stroke of unclear onset or wake-up stroke, what do we do for mild and non-disabling strokes, and then the updates with thrombectomy for large vessel occlusion, middle vessel or medium vessel occlusion, distal vessel occlusion, as well as large vessel occlusion with large core. And then a couple of words on the initiation of secondary stroke prevention. I know you will probably be getting or already gotten a talk about secondary stroke prevention, so that's not the focus of this talk. But when we do have a patient with TIA, we do think about this in an acute fashion, and we think about what can we do or should we do now to prevent them from having a stroke in the near future. And then I'll talk about telestroke and some updates and updated data about telestroke in Sovah Health. So I think that all of us know that we live in Virginia, North Carolina, South Carolina. We are in the stroke belt. And so we do have the highest incidence of stroke in the United States. It is thought that the stroke belt is mostly driven by uncontrolled hypertension. This area of the US has the highest rate of hypertension, and that's what drives the higher rates of strokes as well. Every year, about almost 800,000 in the US have a stroke, of which about 25% of those are recurrent stroke. And when we talk about stroke in general, we mean either ischemic stroke or intracerebral hemorrhage or aneurysmal subarachnoid hemorrhage. That's what stroke means. Today's talk is focused on ischemic stroke, which is the most common type of stroke. It occurs in It accounts for about 87% of all strokes. The most common type of stroke is intraparenchymal hemorrhage, which is 10 to 20%, and subarachnoid hemorrhage is the least common type of stroke, but it's also can be fatal, and it is at 3%. The risk of having a stroke more than doubles each decade after the age of 55. That doesn't mean that we don't see stroke in young individuals. I have patients who've had stroke in utero that I follow, and stroke as a child. So strokes can happen at any age, but definitely age alone is a non-modifiable risk factor. So keep that in mind. And then the risk of having a first stroke in the US is nearly twice as high for Blacks than whites, and Blacks have the highest rate of death due to stroke. And also this is mostly driven by hypertension. Because women tend to live longer than men, they have a higher lifetime risk of stroke, and stroke actually kills twice as many women as breast cancer. So just putting this into perspective, that stroke is a real important public health issue that we have to address it in multiple ways, including stroke recognition. And, as you may know, May is Stroke Awareness Month. So it starts with stroke symptom recognition, presenting to the ED, so in a timely fashion, so patients can actually get the treatment that will actually make a difference in their life and disability. Stroke used to be, in the past, symptoms that lasted more than 24 hours. Now you can have, the definition has changed actually in 2013 to be more tissue-based, meaning that even if a patient presents with 5 minutes or 1 minute of tingling in the finger, and this goes away, and you do an MRI, and the MRI shows a small stroke, that's considered a stroke. It's a tissue-based diagnosis. And that's important because we know that sometimes that even minor strokes can have long-term consequences like depression, cognitive impairment, and other things. So again, it's important to understand what is a stroke, and I refer you to that manuscript that I have here on the slide for the most updated definition, and it's already more than 10 years ago. And stroke refers to having actually symptoms, even if they resolve, versus silent infarction, which is infarction seen on an MRI of the brain without associated symptoms. That could be, for example, doing an MRI for headaches, and then you end up finding a stroke. That's called silent infarction, and the patient may not have had any symptoms, any focal symptoms to go with that. So the stroke symptoms, mnemonic that we try to educate the public with, and of course it's not non-inclusive for all stroke symptoms, is BFAST, which is balance, eyes, face, arms, speech, time to call 911. And the stroke symptoms are gonna vary depending on where the stroke is in the brain, right hemisphere, left hemisphere, if it's a brainstem stroke. And the brainstem stroke symptoms tend to be sometimes very elusive. Patients can present with altered mental status or decreased consciousness. They could be weak on both sides, so they also could be missed, or having nausea, vomiting, no other apparent symptoms, feeling dizzy, complaining of blurred vision. But also there are the non-traditional stroke symptoms, which I think we should, sometimes I see people dismissing strokes because someone said, I feel weak all over, and no, this couldn't be a stroke. That's incorrect. Stroke, think about it as a systemic manifestation. So when somebody is having a stroke, there's actually neuroendocrine changes, there's sympathetic system changes, They could feel tired, they could feel fatigue. Sometimes, often actually, they present also with concomitant chest pain, shortness of breath, feeling confused, or sometimes a sudden behavioral change. So don't dismiss a stroke if you have these symptoms as an accompaniment to other stroke symptoms. And someone saying, I suddenly feel confused, even if they don't have any weakness or numbness, that still could be a stroke, because again, strokes can sometimes just cause acute cognitive change. And these tend to be more common in women. Also, a stroke is not always obvious. You know, there are stroke mimics. Most common stroke mimics for stroke are seizures and thoughts paralysis, so paralysis that results from seizures, metabolic encephalopathy, and I've definitely seen it where if the blood sugar is really low, it doesn't only cause generalized symptoms. The symptoms can be pretty focal. Same thing for severe hyperglycemia, more than 400 blood sugar, significant electrolyte abnormalities, hepatic or renal encephalopathy, infectious encephalopathy, migraine with aura, Bell's palsy, functional disorders, intoxication, neuromuscular like Miller-Fisher syndrome can manifest as multiple cranial involvement, and that could look as if someone is having a brainstem stroke. Brain tumors, subdural hematomas are not, sometimes they are isodense, harder to see, and they can cause focal symptoms, demyelinating lesions, peripheral vertigo. So now we move on to common stroke terminology and scales. And as a reminder of the vessels and so a quick reminder for the brachiocephalic artery here, you have the carotid that divides into internal and external, and you have both vertebral arteries that take off from the subclavian arteries. And when you're going to hear a lot of terminology, usually if you're reading any literature or talking to a vascular neurologist or reading a radiology report, this is M1, M2, M3, what do these mean? M1 means proximal MCA, M2 is this loop in here, and M3 is the cortical branches, M4 are the more distal branches. And again, M2 is that Sylvian section. For the vertebral artery, as you can see here, the vertebral arteries are very, very close to the spine. They are actually, pre-foraminal before they go to this canal. It's called V1. V2 is where they go in the foramina here. And then V3 is from the C2 to the dura. And V4 is intradural. The most commonly used scale to assess stroke severity is the NIH stroke scale, is from 0 to 42. 42 means that the patient can't do anything on the scale, and 0 means that they have no symptoms whatsoever on the scale. It is heavily skewed for left hemispheric strokes, so the numbers can be low for right hemispheric strokes, and the patients can still have significant disability. Also, believe it or not, you can have a stroke with an NIH of 0. It doesn't assess gait, and in my opinion, if you don't assess gait, you haven't had a complete neuro exam. So for someone who tells you, I'm here because I'm busy, and you do the entire NIH stroke scale and they have no ataxia, they still could have an actual cerebellar stroke with no ataxia. And the only manifestation is going to be possibly nausea, vomiting, and unsteadiness. And so I've given actual thrombolysis to an NIH of 0 when the symptoms were disabling, and it did turn out to be a cerebellar stroke. If you have administered the NIH stroke scale, you may have noticed recently that the pictures on the NIH stroke scale has changed. This was pushed by the American Heart Association to be more contemporary and avoid stereotypes. The previous picture used to depict a woman washing dishes and kids about to fall. Now you can see here a painter who's about to fall and here, and then some other mass and the dog running. And also there were changes in the items, and these items are, some of them may be a little bit more hard to name. The most common stroke functional outcome that you will see in almost all of the clinical trials for stroke is the modified Rankin scale. It's an actually pretty simple scale that goes from 0 to 6, and it does include death. So 6 means dead, and 0 means no symptoms, completely back to baseline, able to do all the previous activities before the stroke. Usually a good outcome is considered 0 to 1, and in some studies 0 to 2, meaning only no significant disability or slight disability. 3 is moderate disability, but still able to walk, unassisted, even if using a walker, but nobody holding onto that person, is a 3. And then 4 is moderate severe disability. 5 is requiring constant nursing care. I wanted here to mention just real briefly the role of the non-contrast head CT in the acute stroke evaluation. The reason why we do a CT is not to find a stroke. Obviously, you can have a stroke with a completely normal CT. It is to look for hemorrhage, and hemorrhage would look as hyperdense in here compared to normal brain parenchyma. You can have early ischemic changes like that. You can have an old stroke where it looks, this is really old, looks like the CSF fluid, and you can have something like a hyperdense MCA. This is a non-contrasted CT, and so finding this brightness in here in the MCA tells you that there's a clot in that MCA, even without getting any CT angiogram. And then there's the aspect score, which again, if you're reading any or trying to interpret any of the trials for thrombectomy, you're going to read the aspect score in there, which stands for the Alberta Stroke Program Early CT Score. It is designed to quantify the severity of brain parenchymal changes in acute stroke. There are 10 areas that are assessed, and you take away 1 point for each area that is hyperdense. So an aspect score of 10 means it's a normal CT in the MCA distribution. You're not finding any involvement or hypodensity in the MCA distribution, versus an aspect score of 0 means it's a complete MCA stroke. It's all the MCA territory is affected. And then there's the TICI, which is thrombolysis and cerebral infarction perfusion category. So if you're familiar with the TIMI for the myocardial infarction, the TICI is for cerebral infarction with 0, meaning no perfusion. There was an attempted thrombectomy, but it was really not successful, versus grade 3, which complete perfusion and the blood flow is completely back to normal. And then there's the classification of hemorrhagic transformation of ischemic stroke and reperfusion therapy. So if you do get scans after giving thrombolysis and you see some bleeding, it's important to assess, is this how bad it is? And so you can use the Heidelberg bleeding classification. And small petechial hemorrhage here would be an HI1. More confluent petechial like here would be an HI2. Parenchymal hematoma with less than 30% of all affected tissue is PH1. Intracerebral hemorrhage that is more than 30% of the affected tissue, that's PH2. And then you have other intracerebral hemorrhage that is outside the stroke bed or subarachnoid hemorrhage, subdural hemorrhage, intraventricular hemorrhage. So, and now we can move, now that we have all that background, we can talk about what are the major updates with acute ischemic stroke management. And as you know, time is brain. And for the primary stroke centers, the goal of door to IV thrombolysis, door to needle time is 60 minutes and 75% or more of the patients, and within 45 minutes and 50% or more. So that means that when we're partnering together to treat these patients, we are all running against the clock, and it doesn't work. It's not going to work to reach the time set for primary stroke centers, except if we work very closely and very efficiently in getting the information we need from the patient, and reviewing the chart for any contraindication, talking to the patient about contraindication, checking the blood work, getting the CT in a timely manner, examining the patient, talking with the patient about the options, and giving thrombolysis if they meet the criteria and they would like to proceed. And we need to do all of that within 45 minutes. That's the goal. For comprehensive stroke center, it's actually 30 minutes. So 85% or more within 60 minutes, 75% or more within 45 minutes, and we have to get 50% of our patients thrombolysis within 30 minutes. There's something similar for the device deployment for thrombectomy is 90 minutes for patients treated with thrombectomy who come to their own ER. But if you're actually expecting someone to come, like transfer, for example, from Danville to Duke, coming for thrombectomy, you only have 60 minutes from the minute they hit our emergency room to when the device is deployed. And then for transfers, there's also a goal for that. So if you're transferring someone via telestroke for thrombectomy, the goal is for that transfer to occur from the moment the patient hits your ED to be transferred is 90 minutes per HAASA target stroke, and 120 minutes still per the Joint Commission. So again, all the work involved in acute stroke management is very time dependent, and we have the pressure to meet these goals. I'm not going to go into the details of TPA. I think, you know, I think all of you know about TPA, and actually, believe it or not, some of the newer residents actually have not heard of TPA because it's already been replaced by TNK for the past few years in some of the hospital systems. But tissue plasminogen activator, or TPA, was FDA approved in 1996 based on the NINS TPA study that showed decreased disability and improved functional outcome at 90 days for those who were given TPA as compared to not. And the risk for bleeding was higher in those who got TPA. The risk of bleeding, symptomatic bleeding, then was 6.4%. That was the basis for FDA approval of TPA in the US. And then the European study ECAS 3 tested TPA between 3 to 4.5 hours. And that study was published in 2008. The practice parameters changed in 2009 to give TPA up to 4.5 hours, based again on that positive study that showed improved clinical outcomes when it's given between 3 to 4.5 hours. But since this study didn't occur in the US and didn't involve US sites, the FDA never approved TPA outside of 3 hours. And that remains the case to this day. But we still do it up to 4.5 hours based on AHA guidelines. So the IV TPA improves outcomes regardless with all the time windows within 4.5 hours. After 4 hours and a half, there's really no benefit in giving TPA or thrombolysis. Also, it helps in patients who are less than 80 years old and more than 80 years old, so age is not a factor there. And then it helps regardless of the NIH stroke scale, and will, as long as the symptoms are disabling, TPA will help. Actually, the mortality was no different at 90 days. So I know that sometimes people say TPA saves lives. It does save lives of disability, but it doesn't necessarily decrease mortality at 90 days.
Do this, and I did not nap. So then I fell asleep during the tattoo, which was great.
That's fine.
So, so first, in terms of assessing if a patient is IV TPA candidate, we need to know, is the last known well within 4 hours and a half, and if there's an absolute contraindication to TPA. Initially, the list of contraindication to TPA was rather long. Now it has gotten really shorter, and it's only if patient is anticoagulated, with an INR of more than 1.7. So they could be on warfarin and their INR is 1.6, they actually can get thrombolysis. If it's a recent DOAC within 48 hours and their numbers are off, or if you can't check their numbers, but you're 100% sure they took DOAC within 48 hours, then actually that is a contraindication. Stroke, brain surgery, or significant TBI in the last 3 months, previous or current intracranial hemorrhage, or symptoms suspicious for subarachnoid hemorrhage, a low platelet count, AVM, known brain cancer, active bleeding, low blood sugar, wait till you correct it and see if the symptoms resolve. And then like heart surgery within 7 days. And if the CT already shows more than a third of the cerebral hemisphere being affected. Infective endocarditis is a big one. Do not give thrombolysis if you suspect endocarditis. That's almost always going to result in a large bleed. And do not give thrombolysis if you suspect aortic arch dissection. That is almost always going to result in death. Then if the blood pressure is high on arrival, you can use labetalol nicardipine and get the blood pressure to target, and then maintain it less than 180 to 105 after treatment. So in the past, an LP in the preceding 7 days was a contraindication that still could be considered. If there was a surgery, again, discuss risk benefit, except if it's an uncompressible arterial site. Then shouldn't be giving thrombolysis within 14 days. It is probably recommended with extracranial cervical dissection, but the safety is uncertain if there's intracranial arterial dissection. It used to be that any aneurysm was an exclusion. That is no longer the case. If the aneurysm is less than 10 millimeter, it's unruptured, it's still likely reasonable. Also, acute MI, recent MI is still reasonable to give it. IV TPA should not be administered with a treatment dose of low molecular weight heparin, but with a prophylactic dose, it's okay to give it. And also it can be beneficial in patients who have stroke and sickle cell disease. In the past, we used to say this is a contraindication. That is not a contraindication anymore. Here, I just wanted to refer you, I'm not going to go into each one of those, but just tell you, refer you to this reference. The acute stroke guidelines have these great tables. So if you're wanting to go back to how do you manage blood pressure before thrombolysis, we usually start with labetalol, just one push, may repeat another time, but then really go very quickly to nicardipine. Or clofazimine, and keep the pressure less than 180 over 105 after the thrombolysis starts. There are guidelines on how to manage bleeding after TPA. Definitely, you have to stop the thrombolysis, check CBC, fibrinogen level, emergent head CT to confirm the bleed, and then give cryoprecipitates and check fibrinogen level. If it's still low, then give another dose of cryoprecipitate, give tranexamic acid. And then there are also 1% or less risk of orolingual angioedema with thrombolysis. So also there's an entire algorithm to what to do if this were to occur. So now I'm gonna switch gears and talk about tenecteplase. Now the good news is everything that I told you about contraindications to TPA or alteplase applies. It's exactly the same to tenecteplase. So that still applies. I just want to mention that tenecteplase is a genetically modified variant of alteplase. It is more fibrin specific, so it's possibly more quicker and effective clot lysis. It has increased resistance towards plasminogen activator inhibitor, and it has a longer half-life, and thus it's given as a single bolus as compared to TPA that is given as one injection and then an infusion over 1 hour. This is just one single bolus. There are differences in dosing. Tenecteplase, it's 0.25 milligram per kilo. For stroke indication, it's a single IV push over 5 seconds. There's no infusion, flush only with saline. Do not give dextrose in that same line. It is a little cheaper than alteplase, or a few thousands cheaper actually. And it is made by the same company, which is Genentech. We still want to keep that blood pressure less than 180 over 104, and it's the same reversal algorithm if bleeding was to occur. And I'm not going to go over every study that showed the benefit of TNK, but in general, there are multiple meta-analyses out there that summarize all the studies that started from 2010 and going all the way to 2024, examining tenecteplase as compared to alteplase. So 14 major studies, and the evidence suggests that TNK is as safe and effective as TPA for acute ischemic stroke. There's this other pictorial assay of a meta-analysis that looked at the different levels of outcomes and found that across all the studies comparing TNK to TPA, and they found 11 randomized controlled trials. There were, again, no significant differences in the rates of good functional outcomes, symptomatic intracranial hemorrhage, and mortality between patients treated with TPA and TNK. So if you were to take one take-home message from this, is TNK is as good as TPA. At least it's as good. But again, this meta-analysis found that it may be even better in those who achieved excellent functional outcomes and maybe better reduced disability at 3 months. But at the very least, it's as good and it's as safe. And it may be a little better for those who have large vessel occlusion. So this is a meta-analysis focusing only on those who have large vessel occlusion who got TNK. And there's more successful recanalization. There are better outcomes and more functional improvement at 3 months in those who got TNK. So you saw in the past couple of slides, again, the studies of TNK extending all the way to 2024. But the last AHA guidelines for acute stroke management were published in 2019. So I'm sure some new ones are going to come up soon to reflect all the changes and all the newer studies that occurred since then. But as of the last guidelines that we have in 2019, TNK is mentioned to be considered over TPA in patients who are to undergo mechanical thrombectomy. And again, it's based on the studies for LVO showing improved outcomes and more reperfusion with TNK. And the icing on the cake right now is the recent FDA approval for TNK that came on just this year in March 3rd. FDA approved TNK for acute ischemic stroke within 3 hours after the onset of symptoms. You can see here why it's not 4 hours and a half, because TPA was never approved within up to 4 hours and a half. So then the FDA stuck with the 3 hours. And then use the dosing from the FDA is slightly different than what the AHA had put in the statement of 0.25 milligram per kilo. This is more ranges of blood pressure, of weight. So less than 60 kilos, you can see how much to give. And I think this is going to be associated with a new labeling that the company is making that will be much different than the MI labeling. It's a different dosing, and it will be indicated for acute ischemic stroke. So what do we do for patients who present with unclear last known well? There's the wake-up stroke, which remains the one study that really changed some of the practice here. For if a patient wakes up from sleep or just comes altered and we don't know when was the last known well, maybe their stroke occurred in the past 4 hours and a half. It's just we don't know. So if you're able to get an MRI very quickly, and find here whether, you'll see that they have a DWI lesion indicating an acute stroke, but look at the flare and don't find any lesion to correlate with that. That's called DWI flare mismatch. And what that indicates is that the stroke is likely very recent in the past 4 hours and a half. So that's kind of a correlate to say it's likely a recent stroke and it's okay to give TPA. And that study, when you do that protocol, it actually showed benefit when you give thrombolysis to patients who have disabling symptoms and who present with unclear last known well and have a DWI flare mismatch. And that was reflected in the 2019 guidelines for management of acute ischemic stroke. TNK or tenecteplase, there was a study more recently called TWIST that actually tried to do this even in a more practical way and this occurred in Europe with 600 patients who were randomized for 0.25 milligram per kilo of TNK versus not giving any thrombolysis in patients who present within 4 hours and a half of awakening, and they should have some disabling symptoms, and they only used a CT for that to exclude bleeding. But unfortunately, when you only use that CT, it wasn't good enough, and there was no benefit in giving TNK in these patients. So the guidelines remain and the practice remains that if you're gonna give or consider giving thrombolysis for patients with unclear last known well, you have to get an MRI and look at DWI flare mismatch. So how about mild and non-disabling stroke? Do you need to give thrombolysis for these patients? And based on the guidelines, it's actually, if they have non-disabling symptoms, you don't have to, and it's not recommended that you give them thrombolysis, and you can just give them antiplatelet. And this is based on PRISMS here, which was published in 2018, but it was stopped early, and they had defined non-disabling symptoms as low NIH and also the report of the patient. And the Aramis study, which compared thrombolysis to dual antiplatelet therapy in patients who had a low NIH of less than 5 and felt also that the symptoms were non-disabling. But one word of caution here, I do have the discussion with the patient. I always tell them, it's your body. You tell me if you think this symptom is disabling to you, because numbness for a pianist, numbness in the hand for a pianist may be completely disabling. So I always go over risk benefit of thrombolysis. I mentioned these studies. I tell them we can hold off on thrombolysis and give you aspirin and Plavix instead if you think that the symptoms you have right now are very mild and not causing you any disability. And I highly recommend this approach because patients may get their symptoms worse, or in a month or two or a year later, they tell you this numbness that I had in the ED is still bothering me. It's causing me disability, and I can't live my life like that because I lost my job or whatnot. So I think it's very important to involve patients in this discussion. And how about the endovascular procedures and thrombectomies? So in 2015, we had all the studies presented at the International Stroke Conference, starting with Mr. Clean, Escape, and the rest that I listed here, that came all suggesting benefit of doing thrombectomy for patients who have an NIH stroke scale of 6 or more, who are presenting within 6 hours of the stroke, who have good pre-stroke functional status, and who have some preserved tissue, so an aspect score of 6 or more, and who have presence of proximal intracranial artery occlusion. And you can see here a picture to tell you how many patients benefit if you're doing thrombectomy plus TPA versus TPA alone. So you're benefiting 34 patients, and 20 of them will actually be able to live independently by just doing thrombectomy. And if the patient is not eligible for TPA, the benefit is even higher because that's their only hope, is to actually do thrombectomy if they have an LVO. And so that you can see that 44 patients will actually benefit and 22 will live independently. And then the two studies came in 2018, which is thrombectomy after 6 hours from stroke onset, and that includes DAWN and DIFFUSE. And they had different timelines. So the DIFFUSE included patients up to 16 hours, and DAWN up to 24 hours. The core infarct in DIFFUSE was 70 milliliters, and they had to have a number of 15 or more. Versus DAWN, it was per age, and the highest core infarct allowed was 51 milliliters. But both of them showed benefit, and the number needed to treat. So to actually have benefit in DAWN was 2.8. So thrombectomy up to 24 hours. To achieve a good functional outcome, you need to treat about 3 patients to get one to be better. And it was 4 for DIFFUSE. So that's very close or very, very similar to the benefit from thrombolysis. And then how about posterior circulation strokes? Because all the thrombectomy trials, most of them were done on anterior circulation strokes. How about posterior circulation strokes? There are 2 major studies to suggest also benefit from doing thrombectomy to posterior circulation strokes up to 24 hours. The randomized controlled trial is called BEAGE, and it was done in China. And then there is Attention multi-center registry to look at real-life data and also suggested benefit from doing thrombectomy to posterior circulation. And both of these studies were published in 2022. So how about thrombectomy for large cores? There were several studies listed in here: Rescue, Angel, Select, Attention, Tesla, Last. And also their selection were different, all anterior circulation, but now looking at aspect score that were lower than those included in previous studies. So we're talking about 3 to 5 in most studies, and Tesla even included 2 to 5 and Last 0 to 5. And you can see here that the NIH stroke scale in these studies is rather high because these patients have big strokes. And the 90-day outcome is still, there is benefit when you select patients based on these studies. It's just that these are bigger strokes. So it's better to do the thrombectomy than not to do the thrombectomy, but still there's quite a bit of, the endpoint is quite a bit of people who are functionally bedridden or dead. And you need now about 7 to be independent for ambulation. Number needed to treat is 7. So much higher than the numbers that you see for DAWN and diffuse. So the suggested algorithm based on these studies for large core thrombectomies is to look at the aspect score. If it's less than 5, is there an M2 or distal occlusion? If it is M2 or distal only, there's no M1 or more proximal occlusion, then doing thrombectomy is of unclear benefit. If there's ICA or M1 occlusion, you looked at the aspect score. There's just not enough data for an aspect score of 0 to 2 versus an aspect score of 3 to 5. If it's within 6 hours, a thrombectomy is indicated. Beyond 6 hours of last known well, then consider advanced imaging such as CT perfusion to see if there's enough penumbra to proceed. And now the most recent update is thrombectomy for medium vessel occlusion and distal vessel occlusion. In our practice, it used, we know that there's benefit for doing large vessel occlusion, and sometimes we would just, in general, like if there's an M2, say, yeah, let's transfer for thrombectomy. But finally, these studies were resulted and presented at the most recent International Stroke Conference this February 2025. And disappointingly so, but at least now we know, all of them showed no benefit in doing thrombectomy for medium vessel and distal vessel occlusion. And there were 3 of them that were presented: Discount, Distal, and Escape MEVO. There's just no benefit in any of them. No difference in death, and there's no difference in functional outcomes. And Discount even showed some worse outcomes by doing the thrombectomy. So how about thrombectomy and previous disability? We usually don't question, right, giving thrombolysis and previous disability, but you see some people questioning, are we really going to transfer this patient who has had a previous disability for thrombectomy? And these patients have been excluded from all the randomized controlled trials, because usually when you design a trial, you're looking for the maximum benefit, who is the most likely to benefit. So people with pre-existing disabilities were excluded. And then it became a practice, oh, you have a pre-existing disability, then you don't qualify. But there are multiple observational studies comparing doing a thrombectomy versus not in those who have large vessel occlusion and previous disability, and none of them show any worsening. All of them show some benefit in actually doing the thrombectomy and minimizing accumulating disability. It's just that in general, no one is going to be better. No one is going to go back to a better baseline than they were. And then finally, thrombectomy for low NIH, and based on the meta-analysis so far of observational data, it does not support EVT for unselected patients with LVO of the anterior circulation with minor symptoms, but these are only observational data. So if the NIH stroke scale is 1 or 2 and they have a large vessel occlusion, you definitely need to observe them very closely and make sure that they don't progress and don't become a 6, because sometimes hours later their exam can get worse. But if they only have some mild numbness and they have a large vessel occlusion, that's not an indication for thrombectomy. So I mentioned here that I will be talking for just a few words about secondary stroke prevention, and so TIAs should be investigated urgently. And again, I think of them as part of the acute stroke management, because I'm not going to give them thrombolysis, but I'm going to put them on a regimen to try to prevent them from having stroke in the near future, because the highest risk for stroke after a TIA is in the first few weeks. And so there's the ABCD2 score. You can find it on MedCalc, enter all the numbers very quickly and just come up with a score. And if it's a 4 or more on that ABCD2 score, the patient has an indication to be on dual antiplatelet therapy. And this is a meta-analysis of dual antiplatelet therapy and TIA or minor stroke of NIH stroke scale of 3 or less. And what these studies found, whether you combine aspirin plus ticagrelor or aspirin plus Plavix, but our practice is aspirin plus Plavix as compared to just aspirin, that you do decrease more stroke at the, but also increase the risk for bleeding. So that's why the dual antiplatelet therapy should be limited to a total of 21 days. And now I get to my final part of the talk, which is telestroke. And telestroke is an integral component of the stroke systems of care. It was mentioned also in the acute stroke guidelines in 2019. And it is encouraged for networks to adopt telestroke if they don't have acute stroke management on site. And it's a way to just get the care that people need across more geographic areas, and to provide 24/7 coverage for stroke management. The goals of the Duke Telestroke Network is to collaborate with community leaders to improve and expedite stroke care, to provide direct and immediate access to stroke consultations by stroke specialists 24/7 all year long. We've gone live in 2013 and have been live ever since, covering telestroke 24/7, and to also accelerate transfer of emergent cases requiring intervention. And our goal is not to transfer everyone. We work with the sites to build their own stroke centers, which you have a great stroke center in Danville and Martinsville, and to retain appropriate patients in the community, and assist with patient care remotely when needed, and only transfer the patients who actually really need to be transferred because they need this, like thrombectomy or be in a neuro ICU and need that more specialized care, because patients definitely prefer to stay in their communities if they don't need the transfer. And so the process is to call us, and we discuss the case, then we review imaging, we see the patient, and we call back with plans, and then we work on the transfer for if the patient needs to be transferred. These are some of the numbers for calendar year 2025 for Sovah Health, 908 telestroke consults for this past year, with 91% of telestroke consult cases retained at originating hospital. We had 30 transfers for potential thrombectomy and 77 thrombolytic administration. And 67% of patients who came to Duke were discharged to home, rehab, or original facility after transfer. These are here, the numbers. You can see that over the years, between 2014 to 2024, these numbers of consults have gone quite up, reflecting also more indications for intervention. And you can see here the thrombolysis rates, as well as the percentage of total patients transferred, which is 9% and 10%. So most of the patients stay on site. And these are the outcomes for those transferred to Duke. Again, about 39% have gone home last year, 27% gone to acute rehab. And then you see the rest, skilled nursing facility, hospice 6%, deceased 10%. And these tend to be the sickest of all stroke patients. And then finally, some other updates were that Sovah has transitioned from alteplase to tenecteplase for acute stroke treatment in July 2023, has successfully recertified the primary stroke center The goal was to achieve monthly average of 15 minutes for patient arrival to telestroke page, and that is now achieved. And continue to work on door to needle within 45 minutes, and excellent post thrombolytic documentation. Continue to work on decreasing the door in, door out time, and to continue to track and report the post thrombolytic hemorrhagic transformation rate, which is about 2%, which is similar to what is reflected in the literature. And this is really my last slide. The take-home messages is absolute contraindications to IV thrombolysis have decreased with time. Tenecteplase is not inferior to alteplase and may even be superior in cases of large vessel occlusion, and it is now FDA approved. Consider DAPT for mild and non-disabling stroke instead of thrombolysis, but be sure to discuss with patient and get their input on what they think is disabling. And thrombectomy improved stroke outcomes in selected patients with LVO within 24 hours, including in posterior circulation and in certain patients with large bore infarcts. Thrombectomy may be beneficial in individuals with previous disability. And based on the most recent studies, there's no benefit for thrombectomy in medium and distal vessel occlusion, and telestroke remains an integral component of stroke systems of care. And with that, I want to thank you, and I think we did okay on the time given the initial delay. So feel free to email if there are questions.
You did great on the time. Mary, do we have any questions in the chat?
There aren't any questions in the chat. Oh, wait.
There are?
Yes, there is. We just had one pop on. Okay.
Go right ahead. Okay.
From Dr. McIntosh. Good evening, everyone. Thank you so much for the excellent updates and refreshers, Dr. El-Husseini. How do you manage your patients with severe familial hyperlipidemia as their only risk factor for TIA and CVA and intolerance to statins? Thank you.
Yeah, so good question. I refer them honestly to our cardiometabolic prevention clinic. So I work closely with our cardiology group in that clinic. Unfortunately, that adoption of, and maybe that is reflection of the training, right? Like we do quite a bit of primary care in our own stroke clinic and managing blood pressure, but we typically as neurologists don't manage diabetes. We don't manage, we prescribe statins, but we don't prescribe PCSK9 inhibitors. But usually that's what I recommend as a PCSK9 inhibitor. And I end up sending these patients to the cardiometabolic prevention clinic or back to their PCP if the PCP feels comfortable with that if they are intolerant to statins.
Mary, are there others?
Nope, that was it, Dr. Moore.
Yeah, I was really impressed when you emphasized the really atypical ways in which stroke can present. It's very similar to the atypical ways coronary artery disease and ischemic heart disease can present, particularly in women, where literally virtually any symptom you need to seriously consider coronary heart disease in middle age and well, even younger women when they present. So I think the same is basically the true for stroke also. And the other thing I really appreciated you making a point about was evaluation of gait should be part of every neurologic exam. And that's what I was taught. And that basically you have to, so many patients when admitted are on a stretcher in a bed, and you try to run through a 5-dimensional exam with the patient, and you don't ever get them out of bed. And like low pressure hydrocephalus and obviously cerebellar lesions, you basically have to do that. Mary, I think we have a couple of hands up, including Dr. Walsh.
Go ahead, Dr. Walsh.
Yes, hi, Dr. El-Husseini. I'm the Dr. Walsh, the neurologist in Martinsville, and I want to thank you for a very comprehensive talk and all that Duke does to help out with the strokes. I just wanted to make one point. You talked about the non-disabling strokes, and one that is often missed is the visual field loss from a posterior cerebral artery stroke. So I try to stress to the emergency room doctors and everyone to check visual fields, because that may be the only symptom, and they may not even know that they have a visual field loss, but they lose the ability to drive quite frequently.
Right.
Yeah,
Yeah,
100.
DMV
Yeah.
rota requires you to have that reported. Yeah.
Yeah, so absolutely, 100%. I think if we only rely on defining mild symptoms by an NIH, because it goes all the way up to 5, but you can have complete vision loss, complete, at an NIH of 4. If you infarct both posterior, like both PCAs, you have an NIH of 4. And you're very disabled. So I think that it's very important to again assess as a physician what is a disabling symptom, but also get the input from patients, because I've had patients who tell me, yeah, I feel numb, and even though it's an NIH of 1, it's my dominant hand, and I work as a pianist, or I work on the line of packaging food, and if I can't feel the cold and the hot, I can't continue my work. And so it's very, very important to do a good assessment, and also get the input of the patient. But I agree with you, there are patients who tell you there's nothing wrong with me, and these tend to be right MSA stroke with anosognosia, or even right PCA stroke, that they have a visual field and they don't even know it. And so very important to get a good assessment.
Mary, were there others in the chat?
No, that's it, Dr. Moore.
Any other questions from anyone on the call this evening? I thought it was very remarkable that the majority of the patients who are thrombolyzed in either of our 2 ERs, Danville or Martinsville, do remain in Danville, and I think that's just remarkable. The other number I've seen in the past, and maybe this was from Dr. Coles, who was an early developer of the telestroke program, that well over half the people leave hospital coming in with a major stroke compared to before we had thrombolysis and telestroke programs. It was around 10 or 20%. So this program has had an enormous impact on helping patients survive a stroke and return often to functionality, but to still be alive. Final call, any questions, comments, concerns? Well, Dr. El-Husseini, thank you so much for a great presentation. We do appreciate you doing this for us. For everyone else on the call, thank you for being with us. As I try to always remind the residents when I'm speaking with them, please be careful out there as you go back to your daily work. We hope we'll see each of you next week when Dr. Liu will be here, same time, same station, to talk about dementia, how you diagnose it and separate it into some of the different forms, and talk about some of the drugs that can be used for that. And also importantly, the new FDA tests for screening for Alzheimer's, its limitations, and when one should be trying it. So have a great evening. Thanks for being here. Bye-bye.
Thank you. Take care.